I'm actually finding it hard to believe that they're trusting me with this handheld mic because I tend to be a hand waver when I'm talking. So someone signal me if you can no longer hear me because my hands are flailing around as I'm talking. You guys just all wave your hands at me, okay? So I'm Carmen Helmley. I'm an endocrinologist from Calgary, and I feel like I'm potentially the person who coined BIBIT way back in the day. Through a pilot project that I started working on as a medical resident, and then it's evolved into this bigger project. So I'm really proud to be here today to share the background of how this has come to be, the literature around why we feel this is very important, and then the steps we will take together to be able to bring you together with us and moving this project forward. So I've been tasked with the role of telling you today what is basal bolus insulin therapy and what's the fuss. So I don't think it surprises many of us to know that diabetes management is often overlooked in hospital. And this is because most of our patients, when they come into hospital, don't have the label of diabetes as being their chief complaint when they walk in the door of the emergency department or onto the inpatient unit. Majority of hospitalizations are not directly related to diabetes, and many of our patients have many other comorbidities, and diabetes may be the 7th or 8th or 12th thing down the list. So it's hard to give it its due diligence when we're taking care of patients in hospital sometimes, as other issues do sometimes take priority. Furthermore, there's no immediate short-term visible or physical consequence to hyperglycemia. And so as Dr. McKean alluded to earlier, it tends to be one of those things that we care a lot about hypoglycemia. Patients feel ill, we feel a sense of urgency around hypoglycemia, and it gets treated quite quickly and sometimes even over-aggressively in hospital. But with a higher blood sugar, there is a culture of compliance saying, well, you know what? At least it's not too low, and this is okay in hospital. And this is part of what we're trying to recalibrate during this initiative, is to say that those high blood sugars are also harmful for patients. And they may not have that immediate effect. We may not see that immediately, but we can show you from the literature that there is direct harm associated with that, and we'd like to overturn that rationale of saying, well, it's okay to manage this patient with high blood sugars in hospital. And then lastly, it's typically felt to be an outpatient issue. If we can just get them over this acute hurdle of their acute hospitalization and then just shuttle them out the door, then either their family doctor or their hospitalist or their endocrinologist can deal with their high blood sugars after they get home from hospital. And again, that's something that I'd like to show you today is not the proper way of thinking about it, because there can be direct harm associated with high blood sugars in hospital. So what are the benefits due to improved diabetes care? Well, there are health system benefits in terms of shorter length of stay, fewer complications in hospital, decreased morbidity and mortality for patients. And much of that evidence does come from critically ill patients, but there is also an evolving cohort of literature around the non-critically ill patients as well. And we know that improving this results in substantial cost savings for us in hospital. But on top of that, there's also the patient-specific benefits. And we know from our survey and from the literature that patients are currently quite unhappy with the way diabetes is managed in hospital. And being an endocrinologist who sits on the other side of the desk as patients come out of hospital, I hear no end of concern from patients in terms of how a sliding scale, for example, made their blood sugar yo-yo around in hospital. And because it's quite foreign compared to what patients do at home normally, whether they're on oral medications or on insulin at home, there's a level of confusion from patients as well that they just don't understand where this is coming from. So by managing their diabetes differently in hospital compared to at home, we're losing the opportunity to provide learning and support for the patient in the inpatient environment, but we're also implementing something that's quite foreign, ineffective, and actually unsafe while they're in hospital. So we know from the Diabetes Canada, literally they changed their name about a week ago, from the Diabetes Canada guidelines, looking back, I could access the guidelines electronically at least 2003 onwards, and we know from at least 2003 onwards, there has been support by the Canadian Diabetes Association or Diabetes Canada for using multiple daily injections or BIBIT for the treatment of diabetes in hospital. And this is because it's more proactive and it reproduces normal physiology much more closely. Despite this, the predominant means of treating high blood sugar in hospital remains sliding scale insulin. And we know that sliding scale is a reactive way of treating high blood sugars. So basically we wait until the blood sugar is high and then we try to push it back down with extra doses of insulin. We know that it's not individualized to the patient often and results in suboptimal glucose control. And the guidelines have never advocated for sliding scale insulin use. The guidelines do say that if a patient's blood sugars are high in hospital, insulin should be used even if it is only temporarily required, or even in those who have not been previously treated with insulin. But again, the recommendation is around multiple daily injections, not sliding scale use. So I'm hopeful that most of the people in the room are familiar with what we're talking about when we talk about BIBIT, but I'm going to take a minute to bring everyone up to speed so we're all on the same page when we're talking about this. So when we ask what is BIBIT, it stands for basal bolus insulin therapy, and there are three main components. The first is basal insulin. So in everyone who does not have diabetes, the liver makes sugar continuously, and your pancreas will make a trickle dose of insulin to balance the blood sugar on a 24-hour-a-day basis. Doesn't matter if you're eating or not eating, that insulin is coming out in a continuous flow. Our goal for patients with diabetes in hospital when we're using BIBIT is to match what their physiologic requirements are for basal insulin with an insulin injection that's a long-acting dose. So basically once or twice daily, we administer a long-acting insulin that would cover their glucose that might rise as a consequence of the liver's production of glucose. The important thing with this is that it should be a safe dose that will keep the blood glucose from climbing or dropping even if the patient is NPO or not eating or eating suboptimally. And so it should be a safe and reasonable dose, and we have some math to back up what that dose should be. The second component is bolus insulin. So the bolus insulin is essentially to cover the rise in blood glucose that happens after consumption of a meal. So if a patient is eating the meal, we give them a dose of insulin that ideally somewhat matches what their intake is going to be. It's administered at the time of that meal. If the patient is going to skip a meal, the bolus insulin is also held at that point in time because they're not expected to have a blood glucose rise after that meal, so they don't need the insulin to be able to counterbalance that. And then finally, the last component is the correction insulin. So what correction insulin is an extra dose of insulin for those times when a patient comes in to the meal with an unexpectedly high blood sugar measurement. And so we know if the bolus insulin matches the content of the food, then if we were to give that same bolus dose to a patient when their blood sugar is normal before a meal, then we would anticipate it to be normal or in target after the meal. If your patient's blood sugar is 15 prior to a meal, and you give them only the bolus dose but no corrective dose, you would expect prior to the next meal that the blood sugar would be 15 again. That's not desirable in our circumstances. So we propose giving a physiologically driven dose of insulin in addition to the bolus dose that will bring the blood sugar back down into the target range prior to the next reading. Does that make sense to everybody? Wave your hands if it doesn't make sense. Perfect. So going back to the guidelines for a second, as I said previously, we recommend, or Canadian Diabetes Association clinical practice guidelines recommend that if insulin is required temporarily in hospital, even in patients with type 2 diabetes who have not been previously treated with insulin, there's evidence demonstrating the superiority of basal bolus insulin therapy over sliding scale in those circumstances. So when we take a step back and we look at where did this evidence come from, there are two main driving studies. The Rabbit2 study looked at medical inpatients, and the Rabbit2 surgery study looked at surgical inpatients. And both of these studies, published in 2007 and 2011 respectively, were multi-center, open-label, randomized control trials. They looked at patients who were between the ages of 18 and 80, admitted to either the medical or surgical units, and in each case they had type 2 diabetes. For the medical patients, they were insulin naive patients, and for the surgical patients, they could be on insulin prior to their admission to hospital or not. They weren't excluded either way. And then there were a number of exclusion criteria if they had diabetic ketoacidosis, liver or renal dysfunction, if they were pregnant or unable to consent, and then depending on if they were a surgical admission for the medical inpatients, they were excluded, or if they were admitted for cardiovascular surgery for the surgical patient cohort, they were excluded as well. For the Rabbit2 medical trial, they looked at the mean daily blood sugar, and the secondary outcome were hypoglycemic events, severe hypoglycemia, the length of stay, and the mortality rate. And for the surgical inpatients, they looked at the mean blood glucose, the composite of postoperative complications, including wound infections, pneumonias, bacteremia, respiratory failure, acute renal failure as their primary outcomes. And their secondary outcomes were hypoglycemia, length of stay, each individual surgical complication, ICU admission, and mortality. When we look at the medical inpatient results, they nicely showed a divergence basically between the sliding scale insulin group and the BIBIT group by about the first day after admission, and that became significant by the second day after admission. On days 2 through 10, the BIBIT group, which is the black dots, consistently had a lower mean glucose than the people in the sliding scale group. And the fascinating thing about this study that diverges, at least from our local clinical practice, is that the team went by and adjusted each of these doses daily. So even if they were on the sliding scale group, the team came by and did progressively higher and higher dosing for sliding scales as the days went on. So despite progressive titration each day, the BIBIT group continued to do better than the sliding scale group, with 66% of readings within target for BIBIT and 38% of readings within target for sliding scale. And it's important to note that in this study, the targets are quite a bit different than what our Canadian Diabetes Association targets are. For this study, the target was 3.9 to 7.8 millimoles per liter. When we look at the surgical patients, very similar results. So in the top, point A, we see that there's, again, a quick divergence between the BIBIT and the sliding scale groups. And the bottom, in part B, we actually see how that breaks down by time of day. So you can see that throughout the day, breakfast, lunch, supper, and bedtime, we see continued improvement for the BIBIT group, which in this time is in white, compared to the sliding scale group, which is in black. Now, when we take a look at how this works, when you look at the literature, part of it is that we're giving more physiologic doses in the BIBIT groups, but also the average insulin dose, despite aggressive titration day by day, was about 3 times that of the sliding scale group when we look at the BIBIT group. So patients in general are getting much more insulin in the BIBIT group compared to the sliding scale insulin group as well. The fascinating part in this study is that they took 9 patients who, despite aggressive increases in sliding scale, still had blood glucoses that averaged over 15 millimoles per liter. And these blood glucoses on the side are in milligrams per deciliter. So if anyone's had their coffee this morning, you take those numbers and divide by 18, and that'll give you the value in millimoles per liter. On day 4, after really aggressive titration of sliding scale, they took these resistant to sliding scale patients and they converted them to BIBIT. So when they did that, you can see almost immediately, day 1 after conversion to BIBIT, these people who we couldn't get control over suddenly came back down quite nicely into a much more reasonable range, and then with titration of BIBIT continued to have improvement all the way to 7 days post-transition to BIBIT, showing nicely that those patients who were not doing well on sliding scale did very nicely on BIBIT. When we look at the Calgary pilot, I'd like to share some of our promising results with you to inspire you to do similar good work at your center. So when we were able to introduce BIBIT on the medical teaching unit in Calgary, and we look at the percent of days that were in target, we saw that we were able to increase the in-target days from 32% on a sliding scale to 45% with BIBIT. This is a blood glucose target of 5 to 11 millimoles per liter, as per at the time it was the 2008 clinical practice guidelines, and there was no statistically significant increase in hypoglycemia. When we looked at individual patient results, very similar to that sliding scale resistant group with Ampira's trial, we saw that when the sliding scale was ordered, we see this expected up and down yo-yoing effect. So unfortunately, if the blood sugar is really high, you get quite an aggressive dose of insulin that's not individualized to the patient. It brings the blood sugar down quite significantly and even sometimes too much. And then in our local sliding scales, unfortunately, when the blood sugar is normal and they're about to eat a meal, no insulin is given, which seems insane. And of course, the blood sugar goes back up again. And then when it goes up, they get lots of insulin and go back down. So we see this kind of characteristic yo-yoing effect with the sliding scale. And then quickly after BIBIT is ordered, we see that the numbers come nicely into target. Day 4 to 17 of the patient's admission, after BIBIT is ordered, only 6 out of the 65 blood glucose readings are outside of target, and none of those are significantly so. When we looked at length of stay on the medical teaching unit after this was implemented, we saw a significant reduction in length of stay of approximately 10%, and this was statistically significantly different. We're lucky now to be able to have some early adopter results from some of our other sites in this intervention. So in Calgary, we have an electronic order set, and so it's slightly different than it is at other sites. And so we'd like to share with you some of the results from other sites that don't have an electronic order set to see if they're getting kind of comparable results. When we look at our first early adopter site that we have results back from, we are able to show a significant improvement in BIBIT ordering. So their site-wide BIBIT ordering was about 17% prior to our implementation, and then it rose by 14% to 31% of patients post-implementation. There was no significant change in hypoglycemia, and we define that as a blood glucose less than 4.0. It remained 10% pre and post-implementation. And there was a significant reduction of hyperglycemic events, and we call this moderate to severe hyperglycemia by the way we've classified it. So those are blood glucoses of 14.1 millimoles per liter or higher, and those values dropped 9% from baseline. And then we have results from our re-implementation, and I did get permission from the hospitalist to say that this is from our Calgary hospitalist site. So. And I'll talk to this a little bit more in a bit, but basically what we saw in Calgary initially was an upswing after we implemented initially, and then practice drift as things kind of went back down to the status quo. And now with our re-implementation, specifically with the hospitalist and their GO initiative through their CHIC committee, we've seen a 13% increase in BIBIT prescription post-implementation. So their starting baseline value was 27%, and it's gone up now to 40% post-implementation over 6 months. There was no change in hypoglycemia. So for the hospitalist group, the pre-intervention rate was 6.8% of patient days that had a hypoglycemic event, and our post-intervention rate was 7.0%, and there was a non-significant p-value associated with that. When we look at the rate of moderate to severe hyperglycemia, or blood glucose is over 14.1, we had a 2% patient day decline from baseline, which was statistically significant. And as well, we saw a 3% reduction in the values that were in the 10 to 14 range as well, so a 5% overall move into target range. And then this was the excellent result that we were very excited to share with them just last week. After taking into account age, gender, diabetes type, comorbidity count, in-target status from the first 24 hours of their acute stay, there was actually a 14% reduction in their length of stay across all of their patients treated with insulin in the hospitalist group. The mean length of stay for the hospitalist group at baseline was 14.8 days, and so this resulted in an average of a 2.1 day reduction in length of stay for that group. So they were really excited to get those results. So hopefully I've convinced you now that this is a worthwhile endeavor. And so basically what I'd like to take you through now is kind of the lessons learned from our earlier implementations, so that hopefully we can recreate the wheel in a sense that we're building on all of the progress and the good things we've learned, but help you so that you don't reinvent the wheel in terms of all of the pitfalls that we've encountered along the way. So the first thing that we would like to talk about is Calgary's first BIBIT implementation. So this is, again, as a resident, this was something I was involved in. And the reason we started this project was because I had noticed, as a little keener endocrinology wannabe fellow, that we on the medical teaching unit were not aligning our practices with the current clinical practice guidelines, or so it seemed. So the first thing we did was look at questionnaires distributed to the medicine residents to determine their comfort with treating people with diabetes and their opinions of sliding scale insulin practices. So I got a decent response rate from the residents. It was a 57% response rate, and most of them reported being very comfortable treating patients with diabetes. They were very comfortable with prescribing insulin. They were comfortable with the different insulin formulations and their mechanisms of action and their durations of action. And they reported that sliding scale insulin was mostly inappropriate and very rarely used. So I scratched my head a little bit. I was confused by this. So undertook basically the next year a chart audit that occurred at the same time as the questionnaires had been distributed to see what was actually happening in clinical practice. And so a retrospective chart audit of our electronic health record was then undertaken over a 12-month period for the patients admitted to the medical teaching unit. And this was from January 1st, 2008 to December 31st, 2008, concurrent with the questionnaire survey. And it was done with the lens of trying to identify what the current sliding scale insulin ordering practices were at the time. A total of 1,761 admissions were evaluated for a total of over 37,000 blood glucoses. And unfortunately, what we were able to show is that 84% of patients were treated with a sliding scale during their admission. The way it works in our system, when you typed insulin, the first thing that popped up was a sliding scale, and there were 4 pre-populated sliding scales in the system. And the first one to pop up in the system, which is also the most lax of the dosing options, was also by far and away the most commonly ordered. So basically people were just picking off the easiest thing first. And unfortunately, the sliding scale was adjusted on average only once per admission, and 37% of patients were discharged on a sliding scale that was never once adjusted during their hospital stay. So from there, we were able to identify there's clearly a gap between what people know and what they're actually doing. So my first thought was that we would approach this from an education perspective. There was clearly a gap. And so if we just give them the education, then they will clearly realize the errors in their ways and change their practice so that we could fix this problem. So we approached it from a knowledge gap perspective. And what we realized is that knowledge is really only one tiny part of the problem. Education helped, but it definitely didn't solve the issue. I have a picture here of these pocket cards. And so we made these pocket cards that had all of the guidelines and how to order Bibit on them. And the feedback I got consistently was that they loved the pocket cards, but they kept losing them and they wanted more and more and more. And the issue was that the pocket cards didn't actually change any of the practice at the end of the day. They just liked the idea of having a pocket card that they could hold on to. So certainly that didn't fix our problem. The second thing that we did was we got feedback saying, well, sliding scales are really easy for us to order. Maybe if we had a Bibit order set, it would make things a lot easier for us, and then we would do things the way we're supposed to. So we developed this electronic order set, which had all of the components all in one place, similar to the paper-based order set, to say, okay, here are all the orders you need. We'll walk you step by step how to order them. And what we saw initially was a nice decline in sliding scale orders at first. And then, unfortunately, we started to see that practice drift happening again, whereby the sliding scale orders started creeping up again, basically to exactly where they were prior to the intervention starting. So what we were able to show from that is that this intervention is more than just education. It's more than just an order set. And that even if we're in an environment where there's evidence supporting a change and willingness to accept that change, the process of actually establishing and sustaining those new practices is really challenging. And so where this drove us is to looking at what are the evidence-based implementation, science, and knowledge translation strategies that we can use to both promote the behavior change, but then keep it going and sustain it after that. And so from there, we developed strategies and tools that people can use in the pre-implementation period, implementation, and post-implementation period to accomplish that. So in terms of the pre-implementation, the first thing that we looked at was using a tool to be able to help a site self-assess whether or not they have all the pieces in place to be able to accomplish this change successfully. So this is a site readiness tool. I'm sure many of you have participated in the in the assessment for your site. But this is, as I said, a tool that was developed to allow the site to determine if there are any areas that require attention prior to embarking on the project. So are all the pieces and all the players at the table? Are there any pieces that are missing prior to starting down this path? And then the next step is to identify multidisciplinary site champions who are interested in glycemic management and keen to help move this change forward. In one of our first Train the Trainers, we had a set of physicians who showed up and said, well, I was post-call and someone told me to come here, so what is this seminar that we're here for today? And so people weren't aware of what the intervention was. Thankfully, that physician turned out to be an excellent site champion at the end of the day. He's been very engaged and keen and eager, and I think he was nominated because he'd expressed interest previously, but poor guy showed up post-call and had no idea what he was getting himself into the first day. So it's best if you have people who have expressed an interest and have a passion for this at baseline. It's important to have people from each administrative, nursing, pharmacy, and MD group to be able to drive this peer-to-peer change forward. And that's both in terms of the education, but also in terms of social influence and being an opinion lead within that group. So you would like someone who's going to carry some influence with your peers at your groups. And so I'm thankful for this group here today to be able to help bring this change forward. And then the last thing in terms of pre-implementation is to take these champions and these interested individuals and do something like we've got here, where we're doing a Train the Trainer session, where basically we're hoping to impart onto you the tools you need to be able to educate and promote change within your peer group. So one of the other things that we've found to be very important in promoting and sustaining change is to look at the data in order to promote and sustain that change. So how do we know where we're going if we don't yet know where we are or where we've been? The baseline data helps to provide a view of the current state. It helps to provide a stimulus for change and helps each site set goals. One of the common questions we've had at Train the Trainer is, well, what's the expectation? How many people should be using BIBIT? What should the glycemic goals be? How much hyperglycemia is okay? And we don't have direct answers from the literature to support some of those questions, but we do have baseline data that helps us set incremental goals for the site to be able to look at how things are changing over time. And then we can look and say, did we actually achieve the desired outcome as a consequence of that change? Can we evaluate that effect? And did our intervention actually do the improvement that we are looking for it to do? Or was there an unexpected consequence? And if there was, how do we address that and why? So again, coming back to the initial Calgary pilot, we had a group of individuals who were saying, yeah, we're totally following the clinical practice guidelines. We don't need any help. We're comfortable with everything. But then when we came back with the data to show what was actually happening in practice, we were able to show them that what they believed to be doing wasn't actually what was happening in real life. And so that helped to promote change within that group. And then we've seen with our other early adopter sites that seeing the effect of that intervention in terms of the impact on hyperglycemia, the lack of impact on hypoglycemia, meaning that we're not increasing the risk of hypoglycemia with BIBIT, and the reduction in length of stay has been a huge motivator in promoting and sustaining change at the other sites. And then helpful with regard to communicating that effect to the broader group. So we actually have access through point of care testing to glucometer results within Alberta, which has been really helpful for sites that are not electronically driven to be able to give us a sense of what the baseline data looks like at these sites. So this doesn't give us the BIBIT ordering frequency or the sliding scale ordering frequency, but it does give us an indication of what the distribution of blood sugars across the entire site looks like. So here's a screenshot of the dashboard, and you'll find the dashboard link at the bottom of the slide there. So if anyone wants to access it later, you can. And this shows a distribution of those blood sugars from point of care testing. So you can see that for the Grey Nuns, this was from August 1st, 2015 to July 31st, 2016. There was about a 9% rate of hypoglycemia of less than 4%, 65% rate of in-target blood glucoses between 4 and 10 millimoles per liter, 16% rate of 10 to 14, a 6% rate of 14.1 to 18, and a 3% rate of blood glucoses over 18. Everyone always asks, how does this compare to other sites provincially? And it's very similar in respect to this baseline data compared to other sites' baseline data. So the other piece that we're working on is to take that data, take those goals, take your groups, and to identify what might get in the way. And so it's important for us, as part of our implementation strategy, to address the fact that there are many, many shared barriers that are shared amongst all sites that we've been working hard to try to make tools to help overcome and address, but also that each site has its own unique barriers and its own unique facilitators, and the culture of each site is distinct and unique. And how do we help each unique site address their own barriers as well? And so part of our strategy for the day today is to sit down with you in the afternoon and say, okay, what do you anticipate being an issue at your site? And then after that, we'll regroup and have a chat about what are some potential tools to be able to overcome that. The interesting thing is that we've tried really hard to come up with a set of universal tools for some of the common barriers to say, you know, this might be able to help or that might be able to help, but we know from the literature that if we're able to engage with each site and co-develop those tools, that the utility of those tools is much greater and the effectiveness of those tools is much greater. So we very much appreciate your feedback and advice and support as we move forward to try to help with those tools as needed. Part of what we've done prior to undertaking this project is to take a look at not only the early adopter sites that we've already worked with, but also a national scan of other sites across the country who have implemented similar order sets in the past, and contact them and reach out and say, what were some of the things that were really helpful when you were implementing these order sets, and what were the things that got in the way? And so we've got a nice cohort of sites that have all implemented BIBIT type order sets in the past, and we've been able to collate what are their barriers and what were their facilitators and what kind of tools have they been using. And so then our aim is to be able to share those resources back with you. And again, what we found is that every site has many overlapping, but also some unique barriers and facilitators. Some of those known facilitators from the national scan and from our early adopter sites are the presence of multidisciplinary site champions, as I mentioned, having strong administrative support and champion, which I think is going to be a big highlight for your site, having good communication between the team and the patient. So it is a very effective strategy and a very helpful facilitator. Having ongoing multidisciplinary education, and it's very important for that education to be peer-to-peer or profession-to-profession. A good example in Calgary with the hospitalists, they had asked for a set of in-services previously, and I can't count, I think I did 9 initially when I was a resident, and unfortunately, sporadically, very poorly attended each time. And then I'd get another request saying, please come back, not very many people came, can you come back and give another one? And so we tried that, and it just wasn't working. And so finally, we were able to collaborate with the hospitalist and have them co-present, or they presented the majority of it. And it was literally like a standing room only. There were people billowing out into the hallways because having that come from them directly was much more helpful than having it come directly from us. And so that's really important. Engaging trainees, if possible, to promote this change and to take it up is very helpful. And then linking glycemic control to an order set was also found to be a good facilitator. And then building in some direction around hyperglycemia management, which we're aiming to do through changes in policy and using data to support that change. And then finally, eliminating a sliding scale alternative if possible. Barriers, obviously availability and continued use of sliding scale insulin order set is a barrier. So if it's easy and it's a single tick box, it may be easier than the order set that has 4 tick boxes. So you want to make the change as seamless as possible and make it the path of least resistance to change, so to speak. Another barrier was BIBIT orders not being given as prescribed. And so this is something that I think we're going to try to touch in our multidisciplinary breakout groups, but there is concern among sites that don't regularly use BIBIT. You know, for example, if we just heard recently there was a concern from one of the units that a patient was going to get 25 units of basal insulin at bedtime, but the nurse was concerned that the mealtime dose was only 9 units. And so in her mind, it seemed like a very high dose of bedtime insulin. And so she was hesitant to give it without confirming that that dose was okay. There's a concern that giving basal insulin may cause hypoglycemia overnight. And in Calgary, we saw a dramatic increase in overnight testing that was self-initiated by nursing staff as they got more comfortable with the basal insulin. And then we actually saw it drift back down again. We were able to monitor it in our system because initially they were worried. They didn't want to tell us they were worried, but they were, and they were testing more frequently. And then once they got more comfortable with it and saw that they weren't getting that increased rate of hypoglycemia, slowly they backed off on that testing. And so that's part of kind of the communication piece and the education that has to come along with the change. There is still a significant fear of hypoglycemia, of course, in our inpatient community, and so that remains on the forefront of everyone's mind, and so there can be some hesitation around ordering or delivering that insulin because of that. And then a barrier of lack of ongoing education and monitoring. And then finally, just as we saw in Calgary, practice regression in the absence of ongoing support. We are aware that there are issues around the need for titration of BIBIT doses on an ongoing basis and concern around the transition from hospital back to home. And so those are things that we're trying to actively develop tools to help manage. So what do we do with this information? We have this huge list of barriers from all of these different sites across the country. And this is where our knowledge translation scientist comes in. We've actually have someone who can take those barriers and bring them down to their very base level. So what is the true root of this problem? Is it a fear? Is there a problem with the structure of the site such that it's hard to do the blood glucose monitoring and administer the insulin? Is there a cultural problem where there's a culture of compliance around or complacency, around hyperglycemia? What are the true underlying issues of each of those barriers? And then the really interesting thing is that there's a whole science around how do you manufacture a behavior change strategy based on what the actual cause of that barrier is. And so we're working closely with her to be able to take those barriers and specifically pinpoint, kind of like a good massage therapist can get into those spots. This is what our KT scientist can do. So she takes those barriers and then figures out strategies to be able to overcome those using evidence. So when we look at the actual implementation phase, this is where we talk about setting a go live date for the release of the order set, maybe elimination of the sliding scale order set if there is an equivalent at your site. The champions oversee the discipline to discipline education, and we have an implementation binder which outlines many of the available tools at your disposal. But, some of these include, but are not limited to, the order set. There's a blood glucose and insulin log. Through the intervention, we've developed a website, www.bibit.ca, which has all of our education posters, pocket cards, webinars. We're renaming it. Right now it's called the educational resource, but we're going to name it something snazzy, but it's basically a how to order BIBIT, and then all of the different kind of special clinical circumstances that you may encounter, renal dysfunction, steroid treatment, et cetera, all the kind of more complicated patient scenarios and how to deal with them. And then help regarding how this intervention will fit into your current workflow and how we can optimize that. So with the go live date, as I mentioned, the champions hopefully use their site influence to promote that adoption and promote use of the order set in the glucose and insulin record, and field questions from peers regarding education and use of the order set. And then importantly, communicating back to their team and to the inpatient diabetes management team and the DON-SCN regarding ongoing or new barriers and facilitators. And part of what we try to do is loop back with the sites frequently to see if, how are things going? Are things going as expected? Is there anything that was unanticipated that needs a tool to help overcome? How are the tools working for the barriers that we were already aware of? And help roll out additional tools and strategies as required. So the order set, I have here, I think it's the draft before the current draft of the Covenant order set, which, as Glenda mentioned, closely mirrors, while the content is the same, there are some minor formatting changes between the AHS and Covenant order set. It was developed under the guidance of a provincial working group using established best practice and evidence-based clinical practice guidelines. And then after that, we put it through a series of usability testing, got feedback from human factors, made a series of revisions, and then implemented in some of our early adopter sites, and then got feedback again and made another series of revisions after that. And thankfully, we've had the benefit of being able to look at the outcome data in terms of hyperglycemia and hypoglycemia and feel quite confident that we have a safe and effective order set. We always welcome more feedback, so if there are concerns from your site about the order set itself, please do let us know. So the main objectives of the order set are to standardize the insulin orders and to provide guidance around appropriate ordering practice. This is to minimize practice variation, make it legible, fewer errors, and greater application of underlying physiology that better aligns with our clinical practice guidelines. And the goal is to make it very easy to order BIBIT and the patient's home regimen, and hopefully very tricky to order sliding scale. Also provides a framework around appropriate blood glucose monitoring and targets. So we want people, if they're on insulin multiple times a day, we want blood glucose monitoring 4 times daily before each meal and at bedtime. And the target is 5 to 10 millimoles per liter for most patients. Now, people will bring up exceptions, and there are exceptions to that target, but those exceptions are rare. It's uncommon that a pre-meal blood sugar should be higher than 10 millimoles per liter. We'd like to reinforce the existing protocol around hypoglycemia, meaning if a patient has a low blood sugar, we treat with 15 grams of fast-acting carbohydrate, wait 15 minutes, recheck to make sure the blood sugar has come up, and then develop a protocol for management of hyperglycemia. So this may include checking for ketones when a patient has a blood glucose of over 18 with type 1 diabetes. The other important components to include involve using a patient's home diabetes medication management strategy if there are no contraindications and if it's safe and reasonable to do that. So by no means do we advocate that every patient who comes into hospital should be put on BIBIT. Instead, it's quite the opposite. If they come in and they're on something that is safe and reasonable to continue, please do so. Consider BIBIT if they are not able to achieve the targets of 5 to 10 millimoles per liter while in hospital. We use BIBIT if a patient is poorly controlled at home, if they're not able to continue their home treatment, or if they're not meeting the blood glucose targets of 5 to 10 millimoles per liter in hospital. The BIBIT order set components include a total daily dose calculation, which is either a tally of what a patient takes at home over a 24-hour period in terms of their insulin, so that would be their total fast and slow acting insulin over a 24-hour period, or over the last 24 hours in hospital. Or alternatively, if they're not on insulin currently, you can do an estimate of what their total daily dose may be by using patient characteristics and weight. So we advocate using their weight in kilos times 0.3 to 0.5 units per kilo per day. If a patient has type 1 diabetes, if they're a slim type 2 patient, if their age is over 70, if they have renal dysfunction, or if they're hypoglycemia unaware. And I'll be honest with you, for the most part, as an endocrinologist, I start everyone on the lower range of that range, so 0.3 units per kilo per day. If they have significant insulin resistance, if they are taking steroids, or if they are overweight with type 2 diabetes, then we recommend the starting dose for a total daily dose to be the weight in kilograms times 0.5 to 1 units per kilo per day, because they're quite insulin resistant in that circumstance. So in terms of basal options, you have your choice of once daily or twice daily options. If you're giving once daily basal insulin, it's typically half of the total daily dose administered as glargine, and it's typically at bedtime. For the twice daily option, it's half the total daily dose, then divided into 2 equal doses of detamir, Humulin N, or glargine, and it's typically administered at breakfast and at bedtime. Please remember that basal insulin should never be held in patients with type 1 diabetes due to the risk of DKA. And for patients with type 2 diabetes, it actually should only very rarely be held. If it is held, it often results in morning hyperglycemia. And if you're clinically concerned and you have that feeling in the pit of your stomach going, oh, I don't know about this dose, then please tell somebody or call, or maybe the dose needs to be adjusted. As I mentioned earlier, a truly appropriate basal dose of insulin should not cause hypoglycemia, even if somebody's fasting. So it should be safe to continue to give that patient with type 2 diabetes. Remember that an MD order is always required to hold or adjust insulin doses. In terms of the bolus options, we typically take half of that total daily dose and divide it into 3 equal doses of aspart, lispro, or R. It must be held if the patient is not eating, and that is actually specifically within the order set itself. It's included there. And may be reduced if patient is not eating a full diet. And we can consider a reduction of 25 to 50% of a patient's home doses if you think the diet is sufficiently different in hospital than it would be for the patient at home, which is often the case. And then you look at their total daily dose and you choose the correction based on their total daily dose. And it's always the same trait as the bolus insulin. They're administered together in a single dose before the meal. And correction at bedtime is not routinely recommended because of risk of hypoglycemia overnight. So titration, this is the second big part of BIBIT. So the first is ordering it, and then the next is adjusting the doses, because we've literally taken a calculation and made a random stab in the dark at the patient's dose. The goal of the BIBIT order set is to start an insulin dose that is safe for the patient. And so commonly we get feedback saying, well, I've ordered BIBIT, but the blood sugars are still high. We've designed it that way so that it requires titration. Otherwise, if there's a higher starting dose, then your patient's risk of hypoglycemia on the first day is higher, and that's harmful for the patient as well. So we've made it a safe starting dose, but as a consequence of that, we require titration of the orders. So the first thing to do is to take a look at the blood sugars. Have we achieved our target of 5 to 10 in the first 24 to 48 hours? If so, give yourself a high five, that's awesome. If you haven't, then look at the reason why this has happened. So the important thing is to go back and talk to the patient and look at the circumstances around that high or low blood sugar. Was insulin given at the appropriate time? Was it the correct amount? Was there any change in intake? It's not uncommon for us to talk to the patient and find out that so-and-so from home brought in a really delicious cupcake, and I had that just before my blood sugar was taken, and so that turns out to be the reason for the high blood sugar. Was there any change in activity? Was there physio? Did they go off site? Was anything else happening? So if appropriate, you want to increase or decrease the preceding dose of insulin by 10 to 20% to prevent recurrence of that high blood sugar. And this is an important mental thing to remember. It's always the last dose of insulin that's causing the current problem. It's not the current dose of insulin. And so you always have to go back one step to figure out what was the problem with that last dose that caused the current high or low blood sugar. We have a table that's included on the back side of the order set to help guide titration in terms of what the problem is with the blood sugar, and then which dose needs to be adjusted. The blood glucose and insulin record was developed in part because we know one of the facilitators of appropriate glycemic management in hospital is the coexistence of both the blood glucose and the insulin doses side by side in the same spot. So if you happen to have the blood glucoses at the patient bedside and you have the insulin doses on the patient chart, which is in a totally opposite end of the unit, it's uncommon for somebody to take a look at those two things together and to make an adjustment to the dose. And so our goal is to house both of those documents in the same spot so that it makes it easier for people to come by and make adjustments to the insulin doses. The structure of the blood glucose and subcutaneous insulin record is such that it supports the use of BIBIT. It's got the different components listed similar to the order set, so it should make recording blood glucose values and insulin doses quite simple for the bedside provider, and should provide enough information to the ordering provider to be able to do appropriate adjustments. With the order set first, we're just going to work quickly through a case. Now, I know some of you are not going to be the people who are physically ordering each part of the order set, and that's okay, because I think everyone in this room either has to know how to make the orders or how to interpret the orders. And so I'd like to quickly go through a case together to be able to make sure everybody's comfortable with the order set and the different components, and then the blood glucose and subcutaneous insulin record as well. So our case example is a relatively straightforward patient, a 42-year-old woman who presents to hospital with a community-acquired pneumonia, no other comorbidities, and was incidentally found to have a blood glucose of 21 millimoles per liter on their admitting blood work. Ketone testing was negative, the anion gap was normal, so there's no signs of diabetic ketoacidosis. And as a background, there's normal renal and liver function for this lady, and you're suspecting that she has new onset type 2 diabetes, made worse by her pneumonia. So you ideally want to stabilize her blood glucose before transitioning to an oral agent prior to discharge, and we know that her weight is 80 kilos. So if we look through the order set itself, you'll see that at the beginning of the order set you have all of the instructions around kind of administration of the order set itself. So we've got discontinue all previous insulin orders and blood glucose monitoring orders. All subcutaneous orders should be documented on this order set. And any change in insulin orders requires someone to go through and strike out and complete a new order set. We've got instructions for blood glucose monitoring, which will occur 4 times per day and should be done 15 to 30 minutes prior to meals and at bedtime, and as needed if you're suspicious for hypoglycemia. If the blood glucose is under 4, initiate the hypoglycemia protocol, and if the blood glucose is greater than 18, we initiate the hyperglycemia protocol and call prescriber. Any questions around that? So far, no. So when we take this patient who's 80 kilos and we want to calculate her total daily dose, but given the criteria that we have and we suspect she has type 2 diabetes, we would recommend starting 0.5 units per kilo per day in this patient. So we take 80 kilos times 0.5 is 40 would be the total daily dose of insulin. Does that make sense to everybody? So 40 would go in that box, in that total daily dose box. Now, one of the things that we've had feedback on in initial working groups around this is that when nursing staff is looking at the order set, that 40, it stumps people sometimes in the sense that they want to know what to do with the number 40. The 40 is there as an intermediary for the ordering provider to be able to drive the rest of the calculations on the page. It does not mean that the patient's actual total daily dose of insulin at the end of 24 hours should tally up to 40. 40 is merely a stepping stone in the calculation to be able to get to the end product. Most definitely at the end of the 24 hours, when we go back and recalculate the patient's true 24-hour total daily dose of insulin, it usually doesn't add up to that number, and that's okay. It shouldn't, actually. It just helps to drive that calculation. Does that make sense to everybody? Okay. So if we have 40, I want everyone to actually write 40 in there. We're gonna complete the order set. So then when we take our basal insulin, we have 40 as our total daily dose, and we're going to divide half of that into basal. So in our basal box, I think in my slides I have glargine, so we'll choose glargine. And if you remember, glargine can be given once daily at bedtime. And so if everyone can figure out where to put that basal dose and what the dose should be. And then we'll go through. Any questions about that so far? No. So the bolus and correction dose, we want to use the same insulin for bolus and correction. And you'll see you have 3 choices there, the Lispro, the Aspart, and regular. My mic keeps cutting out, sorry guys. And so I think in our scenario, we've used Aspart. So if everyone can check off Aspart. And then you'll see for the bolus insulin, we have instructions to use a home dose if the patient's on this at home, considering that 25 to 50% reduction. The patient's obviously not on anything at home right now because this is a new diagnosis for her. And then if reduced dietary intake or if the bedside provider is concerned, they can always call the prescribing MD to get a dose adjustment if needed. There's also an option there for a patient to adjust their own dose if they manage this way at home and have good control of their diabetes. So if we take our total daily dose of 40 and we figure out how much of that should be bolus insulin, and then we divide that into 3 equal doses, I want you guys to figure that out. And then I'll go through it on the next slide, which I think you all have in your packages anyway, so it's not really a mystery. It's a decimal place. You can round. It's okay. I just said it's a decimal. It's okay. And then from there we want to choose the correction dose, and that's based on your total daily dose of insulin. So if you remember, this patient has a 40, total daily dose of 40. So we're going to choose the total daily dose in the 31 to 50 category there. Take half the daily dose again.
The 20 units?
Yeah, and divide that into 3, which you get 6.7, 6.6. So you're obviously not going to give 6.6 units of insulin. So this is where a little bit of clinical judgment comes in. So if you want to round down a little bit because you're cautious with the dosing, they may be 6 with each meal. If the patient says, well, I don't eat much breakfast and I eat tons of supper, you might go 6, 6, 7. There's a little bit of flexibility with that because these are just starting doses. So some whole number of units of insulin as your starting dose. So there was a question about the bolus insulin, with there being boxes for breakfast, lunch, supper, and then another other box. So the other box is there because we're trying to mandate that all the subcutaneous insulin orders be put on the order set itself. There are times where someone may have say a significant bedtime snack, or maybe on QID tube feeds, bolus feeds, or even for me sometimes when someone's on a continuous tube feed, I may actually give them a little bit of bolus insulin Q6 hours. So it gives the flexibility of being able to do that if we want to be able to do it. Does that make sense? Any other questions? So on the next slide, you guys had all the answers, which I think you all have in your packages. So we ideally wanted the total daily dose to be 40 in that box. As I said, the basal dose would be 20 units QHS of glargine. And then I just opted for 7 units TID with meals, but as I said, there's some flexibility around that. And then your correction based on the 31 to 50 units as the total daily dose. So then I've given in a sample on the next slide of what the blood glucose and subcutaneous insulin record looks like for this patient, and I just want to talk through that for a quick minute. So we have the day the patient is admitted, and their blood sugar is 21. They receive their 20 units of Lantus, and I, as the physician, have decided that I'm not going to give them any additional insulin at that point in time because they're hemodynamically stable. We're starting them on a therapy, and I want to see what the effect of that therapy is without an additional dose of insulin essentially the patient's first dose of insulin at bedtime on their first day in hospital. So I've given my 20 units of glargine, and then the next morning the patient wakes up and has a blood sugar of 17.2. So if we look back at our order sheet that we just completed, we see that there's an order for aspart, and your breakfast dose, presuming the patient is eating, was 6 or 7, depending on how you opted to fill it out. I have 7. And then if you look at the correction chart, for a blood glucose of 17.2, in the total daily dose 31 to 50 box, we have a +3. And so they would get a total of 10 units of aspart with their breakfast, 7 to cover their meal, and 3 additional to bring them down from a blood sugar that's elevated above our target, hopefully back into target by the next reading. I'm going to stop there for a second because sometimes that's confusing for people who are new to it. Does it make sense? Is there anyone who's confused? I hear some rumblings and whispering in the audience, so usually that means someone's perplexed. Everyone's got it? Okay. So as a consequence of that 7 with breakfast and the 3 extra, we were hopeful the patient's going to come in at that 5 to 10 range by the next meal, but lo and behold, blood sugar is 14.5. So at lunch, we get the 7 units for the meal, and according to our correction, they will get 2 additional units of correction at that moment in time. So in the injection, they get 9 units total. Okay. And again, we're hopeful that that's going to cover their lunch, but also bring them back down into target by the next reading. And thankfully, by dinner, patient's blood sugar is 8.9. So we're getting places. So for that blood sugar that's in target, they're going to get the 7 units of aspart for their meal, for their supper, and then they're going to get 0 additional units correction because they're in target, so they don't need any extra correction at that point. Does that make sense to everyone? Okay. And then she must have gone out and had a big dinner because her bedtime blood sugar is 18.8. So part of our hyperglycemia protocol would be for the bedside nurse to call the ordering provider at that point in time to seek guidance because the blood sugar is over 18. So we're asking, do you want to do any additional testing? Do you want to assess the patient? Is there any reason for this high blood sugar? And do you want to administer any additional insulin, or do you want to just stick with the insulin as ordered? So that is the prompt then for our ordering provider to go back and say, oh, I got really busy. I meant to go back and adjust this person's doses over time. I'm going to make an adjustment or a titration based on these doses. So when we look at this patient's new total daily dose of insulin, essentially what we have is that they got 20 of basal insulin at bedtime. The next morning they got 7 of bolus and 3 of correction. At lunch they got 7 of bolus and 2 in correction. At supper, 7 bolus alone. And so if you look at the total daily dose over a 24-hour period, it adds up. So 20 units of basal, 21 units of bolus, and a total of 5 units of correction to 46. And so what we would advocate then is basically a new calculation of their new basal, their new bolus, and their new correction based on their total daily dose of insulin at that moment in time, which is 6 units higher than their original dose, or about a 15% increase from previous. Mm-hmm. So in this patient, there are no orals yet, right? Brand new diagnosis, so she's not on anything else. That's a really good question, and so that kind of gets back to the question of transitioning from home to hospital, and then hospital back out to home again. So we're actually working on a updated tool for that. Some of that's covered in our current educational resource, but it depends. So if there are contraindications to continuing the oral agents, then obviously we want to have them held and restarted when clinically appropriate. If you're starting an oral agent kind of halfway through, it may be safe to overlap with BIBIT. It depends on kind of what the clinical circumstance is for that patient, and so it's kind of evaluated on a case-by-case basis. Does that make sense? So then, as Dr. McKean mentioned, we've recognized that no single point of intervention is going to be sufficient to be able to change kind of the culture of glycemic management and optimization within the system. So we have been working hard to promote systemic changes also to support BIBIT and glycemic optimization in hospital. And so these include changes at the level of pharmacy with patient-specific delivery and formulary adaptation, changes with nutrition food services with meal content and timing, and then policy changes to highlight the harm of hyperglycemia as well as hypoglycemia. So after we've implemented the order set and the education and all of those other tools in the toolkit to be able to support and sustain change, we then switch to a bit of a post-implementation mode where we start looking at ongoing reevaluation of barriers and facilitators. And so we were talking about the importance of providing that feedback so that we can help co-develop some evidence-based tools to be able to overcome these barriers. It's interesting because having gone through this now a few times, we've found that in some circumstances, the list of barriers at the beginning seems astronomically long, and some of them, a handful, turn out to be true barriers, and a vast majority of them actually never come to fruition on go live day at the end of the day. And so part of what we're trying to do is say, okay, this is what your site identified at the beginning as having potential to get in the way of your implementation. What truly did get in the way, and what were figments of our imagination, or things we were going to worry about in advance that we were able to overcome prior to the go live date? What worked and what didn't work? Providing feedback on the tools and the process. Getting a general pulse for the site. How are things going? Are things generally going well, or are there places that we need to intervene? And then ongoing audit data. So I touched on a little bit with data with the point of care testing. That's one piece of what we ask sites to do. And so as I mentioned, with the point of care testing, we don't have any indication of what orders are being given to patients at those moments in time. So we strongly advocate for sites to continue to audit data. So we do a pre-implementation audit looking at the frequency of BIBIT ordering, sliding scale ordering, hyperglycemia, hypoglycemia, and then we do help support a post-implementation audit as well to be able to see how are things going in terms of BIBIT uptake, hyperglycemia, hypoglycemia, etc. Is practice drift occurring? And so we know at many sites at about that 6-month mark we can start to see slippage in terms of BIBIT uptake, and how do we intervene at that moment in time and bring in a new tool or a new way of communicating to help prevent that from happening, and lots of collaborative and joint problem solving. And then the most important thing is communication also back and forth from us so that we can help share the successes at your site and help to intervene if needed. So that brings us to the end, I think, of what I wanted to discuss this morning. So we basically went through what is BIBIT, what is the evidence for it, why are you undertaking this, the how-tos of ordering it, and then what the expectation is from the site in the pre-implementation, implementation, and post-implementation phases. That's a lot of information. And it's probably new to most of you. So do you have any questions? We have some time before our scheduled coffee break. I'm happy to answer any concerns or questions. So the question is what proportion of patients started on BIBIT need an adjustment, and how long should we wait before we do that adjustment? So 24 hours is quite adequate to be able to see if you need an adjustment. And particularly, I made the example quite clear, right? So if we had a patient who had half their blood sugars at target and the other half were just mildly elevated, I would probably opt to say give it 48 hours. But when you have clear, hyperglycemia for the vast majority of your day, I would say 24 hours is appropriate to adjust at that point. And in terms of your answer about the frequency of titration required, I was going to say all. I'm going to look to you for almost all. And I think it just depends. As I mentioned as I was going through, my personal practice is just, I routinely start on the low end of that calculation spectrum for every one of my patients. So I have to say pretty much universally at the 24-hour mark, I have to go in and I have to go up on that dose. I don't know if anyone routinely starts at 1 unit per kilogram for their type 2s. It's in the guidelines and it's in our order set, and I have to say maybe you wouldn't have to adjust as frequently if you started on that end. But my My personal preference is I would prefer to have to go up after 24 hours than to have the patient have a low blood sugar after their first insulin dose and lose the confidence of the patient in that circumstance, right? So when we look at the end of the day after the titration has happened, the dose ranges that we have are perfectly adequate. They make sense. It's just having the gusto to be able to go up on the higher end of that spectrum from the beginning. I'm not sure that many ordering providers do that practically. I think many of us start on the lower end and then after 24 hours go up. The comment was that patients routinely may not understand that the stress of surgery or that their acute hospitalization will have that effect on their blood sugar, where their blood sugar will climb. I have a couple different thoughts floating around in my mind. First is that just last night we were talking about adding a whole section to our BIBIT website that revolves around the patient experience. And so what to expect when you're in hospital, what happens to your blood sugars, why are they monitored so frequently, why are you getting insulin maybe when you didn't get insulin at home. So that's something that I think it does require addressing. The second is that we have a culture in hospitals sometimes saying that, well, yeah, the blood sugars go up after surgery, that's just what happens. But we also have strong data to show that post-operative infections, wound healing, respiratory distress, renal dysfunction, ICU stay, length of stay, mortality, all go up with that hyperglycemia. And so maybe it shouldn't just happen. Maybe we should be more aggressive with bringing those blood sugars down so that the patient and you and I are not all seeing those high blood sugars at that time. And then the final thing, I guess, is that hopefully the goal of BIBIT plus the correction plus the titration is that won't be long-lived for the patient, right? If you see that the blood sugars are up, even if it is in that kind of post-operative period where we do see stress hyperglycemia, so the blood sugars climb because of the stress response hormones that are circulating after surgery, we can address that with this, which is really nice, as opposed to just letting it ride until those hormones wash out of the system. That letting them go does put the patient at higher risk, even though we don't kind of commonly associate that with it. So hopefully from two different perspectives, one kind of helping the patient to understand what's happening, but also rethinking our culture a little bit around how we're managing that and what we're actively doing to fix it. I think both will be beneficial at the end of the day. So in a typical meal tray, they're going to get approximately the same number of carbohydrates per meal, at least in Calgary that's the case. I'm pretty sure it's Nutrition Food Services throughout the province. That does assume that they eat the full meal tray. The expectation regarding carb counting is purely there for patients who have type 1 diabetes, who count carbs, and we've had feedback. For example, I have one patient who was like, so I got a pudding on my tray. I have diabetes, so should I, and it's unlabeled. Should I assume that this is a diet pudding and has 0 grams of carbohydrate in it, or should I assume it's a regular pudding and has many more grams, and how do I dose my insulin according to that, right? And so you can see if she assumes it's a regular pudding, she could have a bad low, and if she assumes it's a diet pudding, she may have a significant high. And so the principles behind displaying the carbohydrates are merely there for the people who are quite specifically carb counting for themselves, self-managing. We do not expect any of the kind of frontline care providers to provide an assessment of how many grams of carbohydrate people are eating. But, if you have a patient that you're caring for who has a delirium and who for the past 3 meals has had no intake, it's to provide some guidance around what we all know as common sense, right? So to call someone and clarify as the ordering provider, say, you know what, Mrs. So-and-so has not had more than 2 bites of her food for the last 3 days, or so-and-so has profound nausea and they're really not going to eat much. What can we do? Let's open this discussion around what can we do for the insulin dosing. I don't feel comfortable giving this full dose. And so that's where that comes in. And so I know there are some other sites that are going in different directions with the carb counting, but we've specifically tried to.
That makes a lot of sense. I guess it's good to know that generally the meals are smooth for carb delivery. I think that's the take home because
yeah.
I really know that.
And nor did I before we started down this pathway. Yeah. That doesn't count stuff being brought in from home or people having extra from the cafeteria. Or I had one lady once who really loved the cheese scones and she'd eat like 7 cheese scones at midnight every night. There's just not, it doesn't take into account that kind of variability, but there is, you know, roughly about the same amount of carbohydrate per meal on the tray. And so, yeah. Yes?
When looking at the point of care glucometer data, post-Vivid implementation, do you expect to see a decrease in hyperglycemia? Is there a percentage that
Oops.
you'd be looking at?
So I have to say that in our other early adopter sites, we've seen between 5 and 9% reduction in hyperglycemia, so that would be nice. Hopefully, be a reasonable target, I think. Yeah. Any other questions? You guys must be desperate for coffee by now. I'm a little desperate for coffee right now. All right, well, feel free to come grab me on the side as you sip your coffee. If you have any other questions, I'm happy to answer them, or at any point later on.